Assalamu alaikum. Good afternoon, good evening, dear colleagues. My name is Khadija Hafidh. I'm a consultant diabetologist based in the United Arab Emirates. It is a great pleasure for me to be joining you today and talk about insulin management during Ramadan in patients with type 2 diabetes. I would like to take this opportunity also to thank the organizers for their kind invitation for inviting me to the conference. Before I begin my talk, I'd like to submit to you my disclosures. And what I would like to do is really discuss the risk factors that are associated with both hypo and hyperglycemia during Ramadan fasting. We will then review the literature and the guidance on insulin management in patients with type 2 diabetes during Ramadan, and then highlight the results of the unpublished global survey on insulin use and its effects during Ramadan. So if we were just to review the epidemiology of type 2 diabetes, we can see that from as far back as the EPIDIA, which is now more than 3 decades ago, the number of days that patients with type 2 diabetes are able to fast average at around 27. What is also quite evident is the effect of Ramadan fasting on glycemic control in patients who have type 2 diabetes that are on insulin therapies. There was a literature review that was done by Al-Aboud, which concluded the following from 16 studies. All the studies except one found that there was either improvement or no change in the glycemic parameters. The incidence of major complications was really quite negligible. Minor hypoglycemia was reported in some studies, but it did not adversely affect fasting. Postprandial hyperglycemia was only a major concern in some studies, and the incidence of hyperglycemia and DKA were quite trivial. So the conclusion from that literature review is that Ramadan fasting is feasible for type 2 diabetes patients on insulin who wish to fast. The only thing that they need to do is, of course, strike a balance between hyper and hypoglycemia. So what are the factors that are associated with an increased risk for hypoglycemia? Listed here are some of the commonest ones, and they include an advanced age with frailty, advanced kidney disease, stage 4 to 5, or end-stage renal disease on dialysis, the presence of hypoglycemia unawareness, poor glycemic control, tight glycemic control, the use of insulin and insulin secretagogues, and acute illness. So some of the medications that are most commonly associated with emergency hospitalization include warfarin, and insulins and oral hypoglycemic agents come very close to warfarin. So does it really matter the type of insulin that the patients are on? And this was studied in a trial that was a multi-center, open-label, randomized trial that looked at the efficacy and safety of insulin degludec combination with insulin aspart compared with the biphasic insulin aspart 30. So these were some of the participating countries. And the conclusions from that trial was that the hemoglobin A1C and the total daily insulin dose did not differ. They were quite similar. But what was really different and quite significant was the amount of confirmed hypoglycemia, and anytime hypoglycemia was significantly lower in the IDEC-ASP group compared to the BiASP 30. So that was about the mixed insulins. What about basal insulins? And the Orion study was an observational study. It was a real-world study that looked at the safety and effectiveness of insulin glargine 300. And so these patients were studied prospectively in a multi-center study, type 2 diabetes patients who had been exposed to glargine 300 for more than 8 weeks prior to Ramadan, and intended to fast more than 15 days during Ramadan. So they were followed up or recruited pre-Ramadan, 1 to 3 months before Ramadan, and then they were followed up during Ramadan and 1 month after Ramadan. And the primary objective was to determine the percentage of people with one episode of severe or symptomatic documented hypoglycemia. Here, the participating countries included countries from the MENA area, India and Pakistan, but there were some patients from North America as well. Most of the patients' age was around 54. They were overweight with a BMI of 29, and the majority of them had a duration of diabetes that was greater than 10 years. So what were the findings? Hemoglobin A1C, the fasting plasma glucose, and the fasting self-monitored plasma glucose levels were all reduced post-Ramadan compared to the pre-Ramadan period, as you can see from the graphs shown here. What was also significant was that the hypoglycemia rates were quite infrequent. So none of the participants experienced severe hypoglycemia. And as you can see there, the incidence of severe and or symptomatic documented hypoglycemia was more or less the same between the pre-Ramadan and the Ramadan period. And likewise, the events for rates for severe or symptomatic hypoglycemia. So those were kind of randomized trials. What we did was also look at the incidence of hypo and hypoglycemia in a real world setting. And this was the study of the DA 2020 Global Survey. We had presented that last year. The participating regions included countries within the Maghreb, Southeast Asia, in the Gulf, in the Eastern Mediterranean area, and the Indian subcontinent, and the various countries shown here represented by their national flags. So in the 2020 survey, we mainly looked at first the difference in the utilization of insulin in the different regions. And what was quite evident was that there was a predominant use of basal analogs in the Gulf region, whereas NPH and human basal insulin was more widely used in the Indian subcontinent and Southeast Asia. And the main characteristics was not very different from either the Orion or the IDEG-ASP trial, in that the average age was about 58, the mean duration of diabetes was around 13 years, and the hemoglobin A1C was between 8.7 to 9.4%. So the main key takeaways from that survey was that patients with type 2 diabetes that want insulin therapy could fast safely during Ramadan. Most of the patients had poor glycemic control prior to Ramadan, which then explained some of the higher rates of hypoglycemia during Ramadan. The hypoglycemic episodes occurred most frequently between 3 and 7 p.m., irrespective of the type of insulin that was used. And in general, the severity of hypoglycemia was quite low, with minimal need for hospitalization. And there was no significant difference in hypo or hypoglycemia rates between insulin analogs versus the human insulins. Now, if we go back to 2019 and look at the hypo events in the MENA study, we can see that patients that were on oral hypoglycemic agents plus insulin had higher rates of hypoglycemia compared to those patients that were on oral hypoglycemic agents alone. And then you have a lower rate when you excluded sulfonylureas. So what we tried to look at this time in the DA Global Survey, so we combine data from both the 2020 survey and the 2022 survey, is again look at the proportion of patients that were on basal insulin and other types of insulin combined with and without the sulfonylureas, and try and analyze what the effects of these combination therapies would be on the outcomes of patients that were planning to fast. So again, more basal insulins and sulfonylureas were used in the Gulf and Southeast Asia, whereas you had a greater use of the premixed insulins and sulfonylureas in the Indian subcontinent. What about the mean age? Again, between 55 to 57 in all the different combinations. And then duration of diabetes, very similar to what we saw in the Orion and the IDEG-ASP trial, average of around 11 years. And the BMI of these patients was around an average of 27 as well. What about the hemoglobin A1C? Suboptimal, with averaging around 8.5 in all the different sort of groups. And then if we look at the actual number of fasting days, and this included at least one day, we see that there wasn't a huge difference, but what is evidence is that there was a high tendency to a higher numerical value. So more patients that were on the other combinations of insulin with sulfonylureas had a higher a number of fasting days compared to the other combination therapies. Then we wanted to look at how many of these patients actually needed to break their fast because of diabetes-related illnesses. And if we were to concentrate on the green bar here, the other combinations of insulin without sulfonylureas, we can see that they are very much similar to the other combinations of insulins that were with sulfonylureas. So there wasn't a huge difference between those two groups. What was different was those patients that were on basal insulin without sulfonylureas had a less tendency to break their fast as compared to the patients that were on a basal insulin with a sulfonylurea. And then when we looked at the patients that fasted and experienced hypoglycemia, again, we see not a very big difference between the patients that were on other combinations of insulin with or without the sulfonylureas, but certainly there was less hypoglycemia in the patients that were on basal insulin without the use of a sulfonylurea. And therefore, this is something that we think that might need to be factored in when we're doing the risk score for patients fasting, eligibility for fasting. One might need to look at those that are on a combination of insulin with a sulfonylurea. What time were these events occurring? Very much like in the 2020 survey, the highest number of hypoglycemic events occur between 3 p.m. and Maghrib time. What about hyperglycemia? Now, we know from the EPIDIA study that there was an increased risk of about 5-fold in patients with type 2 diabetes. One might argue that this was in a time when we were using sort of the older generations of insulin, and therefore patients were not adequately controlled. More recently, we were able to look prospectively, and this was an observational trial that looked at the incidences of diabetic ketoacidosis during the month of Ramadan, before Ramadan and after Ramadan. And we reported that the incidence of DKA was very much similar before and during Ramadan. There wasn't a huge difference in the incidence rates. What about in the global survey of 2022? Here is the data for the patients that fasted and experienced hyperglycemia. And again, we can see that there wasn't a huge difference between the patients that were on these other combinations of insulin, whether they were on a sulfonylurea or not. The rates were more or less similar. The main difference was that the patients that were on basal insulin had less risk for hyperglycemia. And then those that actually needed to break the fast, the highest were among those that were using other combinations insulin with the sulfonylurea. How then do we mitigate this risk for either hyper or hypoglycemia during Ramadan? It would involve having a pre-Ramadan risk assessment that is based on looking at the patient's type of diabetes, the medication that they're on, the self-management capacity, and then paying particular attention on the patients that are on insulin, on sulfonylureas, in order that they may check their blood glucose levels more frequently. And the recommendations of checking their glucose readings is highlighted here. They need to check at least 6 times and agree to break their fast if they've got symptoms or asymptomatic hypoglycemia with readings less than 70, or if they are hyperglycemic with readings above 300, they should be willing to break their fast. So to summarize then, we know that there are some proven metabolic benefits for fasting in both healthy individuals and people with diabetes. A pre-Ramadan risk stratification is really crucial for all patients with diabetes in order to guide them and support the patients with informed decision-making. The use of insulins ranging from rapid-acting insulin analogs, combinations insulin are quite safe, and they can be used quite safely during Ramadan fasting. The doses and timing, of course, should be adjusted during the pre-Ramadan assessment. Patients should be supported during Ramadan with proper dose titration in order to optimize their glycemic control and offer them a safe fasting experience. A post-Ramadan visit is equally important to make sure that the patient can go back to their pre-Ramadan insulin levels and avoid any deterioration in their glycemic control. And with that, I'd like to thank you all for your attention and look forward to taking your questions later. Thank you.